earlier esteemed speakers, Dr. Bichara on understanding patient views, as well as Prof. Abusnana on SMEG monitoring. So I'm going to complete a picture on how to minimize the risk in Ramadan fasting through considering patient education, for whom, when should it be done, and how to do it, with optimal results during this era. So there's no, from my disclosure, there's none related to this presentation. So the outline of my talk is that I'll be covering on these areas. First, the targets for Ramadan-focused diabetes patient education, its timing, means of delivering patient education, and its key components. So this audience is well accustomed to the data supporting focused diabetes patient education during the Ramadan period. Whilst there are many studies with various supportive evidence for this need, a recent systemic review and meta-analysis of 9 studies by Get et al. Presented this forest plot showing improved glycemic control with pre-Ramadan education. Although there may be reporting bias, there is evidence of benefits to people with diabetes that fast during Ramadan. So you've heard from Prof. Abusnana on glucose monitoring to convince you on its benefits as part of Ramadan-focused patient education. In addition, educating to instill better diabetes self-care practices with self-monitoring of glucose and appropriate treatment management would encourage motivation and self-empowerment to fast safely during this period. And these could extend beyond the Ramadan period, as our previous study had found sustained results over 2 years. So who should we target in this education? Well, we know that Ramadan-focused diabetes education should target the 3 groups: healthcare professionals, people with diabetes, and the general public. But what about patient education itself? Not just the individuals with diabetes, but the family and the caregivers, which are the supporting pillars, could make or break an individual during such challenging times. Hence, we'll need to be concurrently educated to play a part in proposing the appropriate values when facing these challenges. And when should this Ramadan-focused patient education be performed? In the recent Dar guidelines published last year and various recent studies, we do know that the pre-Ramadan assessment is recommended to be done at 6 to 8 weeks prior to Ramadan to give ample time for the necessary glycemic optimization, medication adjustment, and test fasting, especially for those at higher risk of complications, yet keen to fast. This should be followed by support during Ramadan period itself. You would have read Prof. Ahmadani's study where telephone support was provided in 2014, and Dr. Lee's study in Malaysia, and I was in Singapore in 2018, with the use of telemonitoring all showing good outcomes. In fact, with the use of advanced glucose monitoring as present now, such as flash monitoring in Dr. Al-Azhari's study, remote professional monitoring is a given. Whilst there aren't many interventional outcome data on effectiveness of remote support during this COVID pandemic period, except the study which I will highlight later, this means of care delivery has been practiced through remote support even in the years before, and this could be further expanded on in this current era. Of note, the experience during Ramadan should be assessed at post-Ramadan as learning points for safer fasting during the immediate non-Ramadan periods, such as in Shawwal, where some will continue to fast, and for future Ramadan months as well. As most importantly, you will recall that this is a factor in the risk stratification tool. So how should we perform these sessions? These programs can be provided in various permutations, as multiple studies have shown, either as group sessions or one-to-one consultations, either in a healthcare setting or in the community by various members of the diabetes care teams, such as the physicians, dietitians, diabetes specialist nurses, and trained community workers. Especially in the Muslim minority countries, the support of religious leaders in these programs is of essence, as culturally sensitive workers for provision of these programs may not be always readily available, and there is also need for overcoming the language barriers. In the current era, the use of alternative platforms could be considered to overcome barriers for access and physical distancing. While traditional means using telephone and mobile phones are probably the preferred modes of communication for the technologically challenged patients, when it comes to education, more sensory involvement may enable better retention. Whilst messaging app groups such as WhatsApp or Telegram can provide brochures remotely and links to reliable resources, using social media platforms can provide a more visual effect to the means of delivering this focused education and cast a wider net in minority Muslim populations, especially those with language barriers as well. However, face-to-face two-way interaction through digital platforms like Zoom can achieve even better satisfaction whilst maintaining physical distancing and reducing risk of unknown exposure for infectious diseases in this vulnerable population. This way of education is useful and could become the default mode for future, in line with WHO recommendation for safe Ramadan fasting and faith-based community activities in 2020. In a recent overview of systemic reviews in whether remote patient monitoring can be the new standard in primary care of chronic diseases post-COVID-19 in the journal Telemedicine and eHealth a few months back, the authors, Muller et al., suggested that there is evidence that support remote patient monitoring to be as effective as standard care, but will need evaluation due to the suggestion of a small negative effect on the physical component of health-related quality of life. In contrast, a comparative cross-sectional study by Motib, conducted in Morocco, compared conventional consultation in the pre-COVID era in 2019 Ramadan and telemedicine in 2020 Ramadan for diabetes, found a significant difference with higher HbA1c by 0.3% and increased fasting interruption in Ramadan 2020, but no differences otherwise in diabetes complications. Hence, further studies to evaluate practices of health-seeking behavior of Muslims with diabetes during COVID-19 and Ramadan, and the efficacy of digital platforms as a mode to patient consultation and education in this context needs to be evaluated. The last part that I'll cover is the key areas in pre-Ramadan diabetes patient education. We are now well aware of its paramount importance in providing the beneficial outcomes. Recent studies reported that attending these programs can improve confidence in diabetes management and also psychosocial factors when fasting. The main areas which should be covered include risk quantification and blood glucose monitoring, which were already covered earlier, exemptions and removing misconceptions, symptom recognition of hypo and hypoglycemia, sick day management and when to break fast, fluids and dietary advice, physical activity and exercise, as well as adjustment of medication diabetes treatment for fasting, which will be elaborated in the subsequent talks. How about physical activity in exercise? Well, it's best to avoid strenuous activity during fasting hours, especially the last few hours before sunset, due to increased risk of hypoglycemia or dehydration during this period. However, in general, people with diabetes should maintain their normal physical activity. A Gamdi recently has shown that via Fitbit device, there is a high prevalence of low physical activity in type 2 diabetes without significant difference from non-Ramadan periods, with short sleeping duration at night and daytime sleepiness. In a recent article, we also opine on a type of less strenuous physical activity, which can potentially be sustained during Ramadan. However, this needs to be evaluated for a diabetes population in question. During Ramadan, there can be an average of more nighttime prayers, especially extra 11 to 23 rak'ah. And these tarawih prayers with the bowing, kneeling, and rising should be considered as part of their daily exercise regimen. Studies have suggested that 12 rak'ahs would approximately be similar to 30 minutes of light exercise. Prof. Shaltal et al. Had also provided supportive evidence that increased likelihood in achieving HbA1c and weight reduction with more nighttime prayers during Ramadan. How about medication adjustment during fasting? This will be covered in the later lectures, but suffice to say that the changes in lifestyle and eating patterns during Ramadan predispose to increased risk of daytime hypoglycemia and nighttime hyperglycemia. As the type of treatment has an impact on this risk, adjusting the dosage and timing will be of essence during pre-Ramadan assessment, together with test fasting and reiterating the dosage for non-fasting periods if there were further glycemic optimization done prior to Ramadan after the test fasting. How about the role of diabetes educators? So what is the outcome that needs to be achieved at the end of the Ramadan education? As it may overwhelm people with diabetes to manage their disease in addition to changes in Ramadan, outcome of pre-Ramadan education should be a personalized care and management plan in line with the diabetes person's lifestyle, behavior, culture, and beliefs, which may be different from the surrounding community. Knowledge of devices used for convenience should be revisited, including use of insulin pens, glucometer, advanced glucose monitoring devices, insulin pumps, and helplines with Ramadan advice, as well as reminders to achieve good glycemic control during Ramadan fasting. Close communication with diabetes care teams can help to minimize diabetes complications and also ease coping during this period. So before I end, here are the takeaway messages. For pre-Ramadan patient education, it is a key component of safe fasting for people with diabetes to be done at 6 to 8 weeks before Ramadan. It improves glycemic control, weight, reduce hypoglycemic events, even in higher risk individuals. It has potential for positive outcomes beyond Ramadan. We do need to target people with diabetes, their families, and caregivers as the support network. It should be delivered with cultural sensitivity, and it can be delivered individually or in groups, face-to-face or virtually through various platforms. These sessions should include risk quantification, SMBG, glucose monitoring, diet, physical activity and exercise, medication adjustment, and dose test fasting, recognition of the symptoms of complications, and when to break fast in order to avoid harm. Amongst its benefits include better nutritional intake, medication dose adjustment for glycemic optimization, healthy lifestyle to guide them to fast in a safe and healthy manner. So before I end, I just would like to wish you an even better Ramadan for 2022 for us to look forward to. And with this, I end. Thank you.